Good afternoon. I'm looking to see if it's afternoon or morning. For those of you who were very conflicted by the signs that said space available and closed in the parking ramp, you've persevered through the rain to get here. Thanks for joining us. There are a lot of seats down front. This may be a little bit like church, so please come on down. My name is Scott Kiefer. I'm Vice President of Public Affairs. You can't hear? Okay, is that better? Great, thanks. My name is Scott Kiefer. I'm Vice President of Public Affairs at Blue Cross Blue Shield of Minnesota. And I think, Larry, this is our 6th year endeavoring on this series. Many of you have been here before. Many of you are new faces, but I'm really excited about today's discussion. Number one, because I think at the highest level, there's probably a surprising degree of agreement between Senator Jensen and Senator Marty on what we need to achieve from an outcome standpoint. And that is, we all would like to get more out of our healthcare system, and we'd all like to get better value for our healthcare dollar. So I think in the spirit of a very difficult, challenging election season and political environment, we should start there, which sets us out uniquely as Minnesotans maybe to lead by example and have this conversation in a very politically and emotionally charged issue and a very politically and emotionally charged environment. It probably goes without saying that our organization is not thrilled with the idea of single-payer healthcare. Nonetheless, I have a profound admiration and respect for Senator Marty and his views, and we've worked together before, and I find him to be a highly principled person, obviously, and has a distinguished career in the legislature, so we're really glad that he's here to present that view. Likewise, Senator Dr. Jensen is someone who I've gotten to know quite a bit over the last couple of years and is equally principled in his view, has a lot of healthcare experience and a unique perspective to bring to the table as a primary care physician. So we're glad that Dr. Jensen could be here as well. So for those of you who believe like I do, regardless of my particular view or my organization's point of view, that we have the lack of space in the political domain right now to have this type of conversation without yelling and shouting at each other, I would encourage you to join us on October the 30th when Bill Galston, who is a scholar with the Brookings Institution and a well-known Washington expert, has long worked in politics, will be here at the Humphrey School on this stage to talk about bringing back civility in politics. So in as much as those of you would say, God, this Blue Cross guy is absolutely crazy, having somebody here a week out from the election to have that conversation, I hope it sets the stage for what we need to do next year when whomever is elected has large and major challenges to confront with a new governor, new legislators, potentially new legislative leadership. So I would encourage you all to join that conversation. As it moves forward today, this is a really exciting day because tomorrow we know that rates will be released on the individual market. So we'll see what exactly the reinsurance program that the state of Minnesota and these gentlemen worked on here is producing for individuals in the individual market. So I will first say that I'm optimistic and hopeful about what that will show, but I also know as an American, as a Minnesotan, it's not really fair to suggest that people should have to spend 30% of their income on health care. So we've got to do something about that. The fact of the matter is, regardless of how much dissonance there may be on an issue like single-payer health care, the role of government in health care, we have a hybrid of a public and private system. That's the reality we face in the United States. We have a very well-functioning Medicare and Medicaid program on many levels that's largely public with some private role in there. And we also have an employer-based system that functions in many regards very well and people are very satisfied with. So one of the things I hope that we get out of today's discussion is the trade-off and the tension between the public and private role in our system, and that we chart a better path forward that's uniquely Minnesotan based on conversations like this and those to come. So thank you, Senator Marty. Thank you, Senator Jensen. And I'll turn it over to Professor Jacobs. Thank you, Larry, for your partnership.
So as we get started, please silence your cell phones. I used to say shut them off, but then I was corrected because I know a lot of you are tweeting and all that other stuff, and that's great. We're very much fine with that. It's just, I don't want you to be embarrassed. If your cell phone goes off, we all turn around and stare at you. It's just for your benefit. But I also want to tell you that a lot of our programs are broadcast by different media or covered by media, including public radio. And when a cell phone goes off, not so good. The other part of that pattern is that we use written question cards. Oops, here we go. And the reason for doing that is not to weed out dissenting views, strong views, absolutely not. I love those perspectives, and you'll see I'm actually biased to them because it makes for an interesting conversation. The only reason we do this is because it helps us to partner with our media friends so they can take a conversation with 150 or 200 people and share it with a couple million. Isn't that cool? So that's the reason we're doing it. We're going to talk a little bit, and then we're going to open it up to your questions. So please participate in that way. So let's get started. I'm very pleased to have with us John Marty, who's been in the Senate for over 3 decades, well-known DFLer who's been talking about single payer for more than a decade, and has been someone who's done it when it wasn't popular, when it was actually the minority view, and has been a very principled advocate for it, and I think you'll see what I'm talking about. We're also pleased to have Senator Jensen with us, who is leader of the Health and Human Services Committee in the Senate. Vice Chair. And also a very principled person, a member of the Republican Party, and I think you'll see why this conversation is going to be very helpful. This is, for me, an opportunity to have an educated conversation. You may agree or disagree with different sides, and hopefully we'll give you ammunition or maybe put you in a spot of some new questions, some new things you want to think about. Senator Marty, let me start with you. We've had some enormous changes in health reform. I think a lot of people are maybe just catching their breath after the Affordable Care Act was passed by President Obama. We've had efforts to repeal it, and there have certainly been some changes, but the basic skeleton of the program remains. How do you feel about that program? Has this been, kind of the landmark we should be focused on improving, or something we need to kind of scrap and start from the beginning?
I'd say it's somewhere, it's not the landmark program. It's not the solution to things. I was working on our proposed Minnesota health plan about the same time a year before President Obama was elected and putting our thing out there, and I suggested we need a fix to the problem, not a tinkering with the problem. And it was more than tinkering because it did cut the uninsurance rates, number of people without insurance by half. It didn't fundamentally change the system in a way that helps take advantage of the excellent providers and excellent healthcare system we have and make it accessible to everyone. We still have millions of people who can't afford any health insurance. We have millions, tens of millions, hundreds of millions who have insurance, but they can't afford to get the care they need. The co-pays, the deductibles, the lack of coverage for dental, the lack of coverage for other things. So I favored it as better than what we had before. As a state legislator, I didn't have a role in it. And my pitch was, let's not do it this way, though. Let's actually fix it.
Senator Jensen, here we've got this new system that's rolled out. Minnesota was in the forefront of implementing both the exchange, which is known in Minnesota as MNsure. We also created what's known as the Basic Health Plan, which is our MnCare program. And we've seen lots of expansion of the medical assistance or expanded Medicaid program. So lots of change. How are you feeling about where things are and whether the Affordable Care Act is, the framework we should be kind of working on?
I think that the Affordable Care Act did bring some real positives to the marketplace, if you will, and the marketplace being the marketplace of ideas. I think that allowing children to stay on their parents' plans till 26 was an idea that was probably past due. I also think it brought a real bright light on to the notion of pre-existing conditions. And this isn't just some sort of elusive concept to me. This is something I've addressed over the last 35 years, taking care of patients. I've seen the 6-year-old come in with the diagnosis of type 1 diabetes, and I've known right then and there that for the rest of this 6-year-old's life, they were going to incur more expenses and spend more dollars and have less likelihood of being able to have discretionary income to do some of the things that other people would do. So we have for a long time avoided an honest discussion about pre-existing conditions. And I think we've done it in part because we've looked at perhaps a few disease entities out there and said, well, those are the product of people's own choices. So that pre-existing conditions, we can sort of take those off the map. And I think oftentimes we looked at tobacco use and said, see, if they wouldn't use tobacco, they wouldn't have that medical problem. If they didn't have that medical problem, they wouldn't be spending the money and they could do it just like everybody else. But that's actually not true. The majority of pre-existing conditions aren't related to choices that people are making. So I think the Obamacare really did a good job of putting a shining light on that. And then I think perhaps the greatest thing that Obamacare did was it really engaged American society. I don't know that it clarified it. I don't think it's the structure that we want to go forward with because I think patients have been left in the dark on some things. We haven't been able to keep our doctor. We haven't been able to keep our insurance plan, some of those kinds of things. But I think it was a strong effort to move the needle, and I think we're starting to really engage in. If we can now do things like this where we say, okay, let's not lock on to something that prevents us from solving the problem. Let's not draw lines in the sand. Let's have the conversation, carve out the common ground, and figure out how the heck do we solve this, and what are the true moral imperatives when it comes to healthcare.
So Senator Jensen, just to clarify for folks listening here, liking your tone but wondering where you are in terms of policy, are you someone who says, look, this was a good effort, as you said, but it's got flaws, and therefore we need to improve it, make changes in it, some of them perhaps structural, or are you on the page of we should repeal it and start over again?
I would say that, again, it might be defining terms. What does restructuring it look like and what does starting over it look like? Quite frankly, the Obamacare moved us a lot towards the Switzerland system, and I think there's a lot to be said for that. So I'm not going to get bogged down in semantics. I think if we want to take some of the structural elements and say, let's go fix it, then let's go fix it. But the idea of tearing it down, taking away what people have gotten, and said, okay, tough luck, we're going to start over again, I think that makes it a political issue, and I think that's where Republicans have missed out.
Senator Marty, you have been talking about single payer for some time now. You've got a plan that you have rolled out, and it's available online for those who want to look at it, the Minnesota Health Plan. You've been advocating for it, as I said, well before people were talking about it broadly. In fact, some of our forums, you were here and you were kind of a single voice. Could you tell us a little bit about what you have in mind?
Sure. Bottom line is, I want a healthcare system that makes sense, a healthcare system that works. We have some of the best doctors, clinics, hospitals, medical technology research in the world, but the worst system for accessing all of that care. So figure out what we want. We want to have a system that covers everyone for all their medical needs, including dental, including long-term care, including chemical dependency treatment, and eye care, and hearing, everything. We want to cover those. We want to make sure that it's driven not by government or by insurance company or employer, but driven by patients and their doctors. So no networks, where people get to choose who their provider is, and that the doctor-patient relationship is where the decision's made, not by some outside entity. Designed a system like that, and the Minnesota Health Plan would cover everyone for all their medical needs. It would be funded, people would, instead of paying premiums to private insurance company, they'd be paying premiums to the Minnesota Health Plan. These premiums would not be based the way they are now, based on age and medical condition. They'd be based on ability to pay. So it would be affordable to everybody, so everybody pays into it, because we all have a responsibility to pay for it, but it wouldn't be out of cost, out of range for other people. So it would be a universal system, cover 100% of Minnesotans for all their medical needs, and we believe it would be cheaper in the process, and certainly it would be fairly funded because we'd all be paying our share.
And I'm going to turn to Senator Jensen in a second, but just to clarify, when you say all Minnesotans will be paying in, this would be a mandate. There would be
This would be a single plan, single payer, single plan. It covers 100% of Minnesotans. We would all be paying into it, yes, and we'd all be covered by it for all medical needs from birth to death. And I think that's one of the things people want. They want predictability in a system. They want to know, when we talk about universal health care, people say, oh, we're going to cover those people who aren't covered now. You know, every insured family also has a problem where their nephew or somebody else can't get the care they need because of cost. So yes, it would cover everybody 100%.
Yeah, my question was about would everyone have to pay in, because the least popular aspect of the Affordable Care Act, otherwise known as Obamacare, was the individual mandate that required everybody, given certain exceptions, to pay in, and the Congress just repealed it. And even among some Democrats, there was support for it. So we'll get back to that issue.
By the way, I don't like the mandated insurance payment, partly because the Affordable Care Act didn't cover dental. If you have rotten teeth and your expense is dental care, you got to buy insurance that doesn't cover your dental care. So
you didn't like the individual mandate for Affordable Care Act. You like it for your plan, though.
I want to have a system that everybody pays into and everybody benefits from, comprehensive benefits.
Okay, thank you. Senator Jensen, we're going to get into some of the details, and you might have some views about that. But before we do, Senator Marty lays out a moral imperative. Universal coverage for essential healthcare services, dental care, across the board. Does that moral imperative and that vision of universal coverage for everybody, for all services, does that strike you as a worthwhile objective that you support?
I don't think that you or Senator Marty get to define what a moral imperative is. And I don't think that I do either. I think oftentimes that boils up from the public discussion. Is it a moral imperative that Senator Marty articulated, that we provide everything that anybody wants, regardless of the cost, and nobody has to pay in? I mean, I was born and raised in Sleepy Eye, Minnesota, and we were always taught that if it sounds too good to be true, it's probably too good to be true. On the other hand, I think it was Vince Lombardi who said to his Packer team early on when he became the coach, he said, we are going to absolutely pursue perfection, and along the way, we are going to encounter excellence. From that perspective, I think Senator Marty's goal is admirable. But honestly, I think that when he articulates that perspective, I don't think it's doable in light of trying to fund education, transportation, and all the other needs. If I could just take a minute to actually talk about numbers, because I'm afraid that single payer has become...
We'll get into that in a second.
Let me finish with one thought then. I think single payer has become a catch-all term that means many different things to many different people. And if we don't define it specifically, it's just noise.
Agreed. And I think that's why we started off with Senator Marty's proposal. Here's an actual plan. We could sink our teeth into that. But let me just get back to this moral imperative. I appreciate your concern that there is not one moral imperative. We're a large country, we're a medium-sized state, lots of different perspectives. What would be your sense of where we should be heading? How would you define that?
When I was first going into medicine in the 1970s, I remember we sat and talked about this in the doctor's lounge. Was healthcare a right or a privilege? I think the discussion's moved past that. I think the discussion now has approached the notion of the United States as a collective body is saying, some basic core package of healthcare has become a moral imperative. We wouldn't want our neighbor, our family, or our worst enemy to have a heart attack or an appendicitis and not be able to go get care. We do not want people dying on the streets of pneumonia because they couldn't get care. So at some level, we have a moral imperative that's been evolving, and the Affordable Care Act raised the level of discussion, and we all need to participate, but we participate not by drawing lines in the sand, but we carve out common ground and say, okay, what's critical? The 10 essential health benefits in the Affordable Care Act go too far. Canada, in their, quote, single-payer system, doesn't provide vision or dental care, doesn't provide long-term care, doesn't provide prescription drug care. So we need to make sure that we're talking apples to apples.
Senator Marty, there's been lots of discussion led by Senator Bernie Sanders about single payer. and we've had quite a bit of focus on, is it affordable? Now, we've had a liberal and a conservative group come out with their estimates, and they turn out to be the same. The Mercatus group came out and said $32 trillion. This is for the national single payer over 10 years. The more liberal Urban Institute came out with basically the same figure. Is this affordable? Is your plan affordable? Is single payer affordable?
Sure. Well, first of all, I would challenge some of the way the economics were calculated in that. But I think both of the plans talked about $32 trillion is what it would cost for healthcare under a single payer plan. And I certainly know the later one. I think both of them talked about how doing what we're doing now was like a couple trillion more than that. So in other words, saying, oh, it's going to cost so much to do this. Yes, healthcare is extremely expensive. It was 1/20th of our economy 40, 50 years ago. Now it's 1/6 of our economy. It's going to be 1/5 of our economy soon. It's a huge sector of the economy, and it's very expensive. My argument is less expensive than what we're doing now is the right direction. Is it very affordable? Well, it's more affordable than what we're doing now, and more affordable than the solutions others are coming up with, because they're not coming up with the solutions. Neither party is. Other than a single-payer system, a single logical way to deliver health care, neither party is coming up with them. Last year, the Republicans offered for-profit insurance companies into Minnesota because that was going to solve the problem, and so we allow them into the company. Well, a for-profit insurance company can only meet its financial obligation to its shareholders by one of two ways, maximizing profits, either by raising premiums or by cutting benefits. And neither of those are things we want to accomplish in healthcare. So it seems to me that the ideas are being thrown out by the political parties in the regular discussion aren't helping, and that a single payer system that, while very expensive, is less expensive than what we're doing now makes sense.
Senator Marty, let me just get back to the nuts and bolts here, because I think a lot of folks are attracted by the vision you're offering, but are probably wondering, wow, how much would this cost? Vermont, which is, for those of you who haven't been there, it's in the Northeast. It's a liberal state. This is where Bernie Sanders comes from. And in 2011, it had a Democratic liberal governor and a Democratic liberal legislature. They passed the first single-payer law. And they got to work. And they made a very determined effort to deliver. The governor said, we're going to lead the country in this. And in 2014, the same governor reported to the state, he said, you know, this is going to cost over several $billion. We're going to have to increase taxes, payroll, and other taxes, and we cannot afford it. It costs almost as much as the entire annual budget for the state. So how do you avoid that situation? You get a governor here in Minnesota, you're leading majorities in both chambers, and all these folks who are saying they support single payer actually vote for it. Are we heading for fiscal disaster?
A couple of comments. One, first of all, Vermont's wasn't what I would call single payer. It was going to cover about 1/3 of their population. That's not what I would describe as a single system covering everyone. So they didn't get the administrative savings and other things like that. If a single payer system is less expensive, and I'd be happy to go into why it should be less expensive, even though we're covering more people for more things. If it's less expensive, then we're already paying the higher cost now, and how we structure the payments in a fair way is the logical thing to do. So instead of paying your premium under our bill, the premiums you'd be paying based on ability to pay wouldn't be paid to a private insurance company or through your employer. They'd be paid to the Minnesota Health Plan. Does not stop at the government. We at the legislature don't have, we spend that money. Well, we need more money for roads or education. No, this money goes, like Social Security, goes directly to the fund that's going to pay out Social Security benefits. The fund goes directly to that. It can only be spent on that. And if the premiums that we pay to that instead of that, if you count that as, new government spending, then it costs more for government spending. It's less spending overall, because if it is less expensive, which again, I'd be happy to give the two biggest reasons it's less expensive. But if it is less expensive, that means we're spending more than that now. We'd be spending less to do it.
You've raised a lot of issues, and I want to turn to Senator Jensen to give him his opportunity. But before I do, I just want to ask you, have you had a group of economists or others come up with some numbers on what your plan would cost? Has that happened?
We have been asking, Governor Dayton actually was put in one year, he put in $500,000 to study this and another alternative proposal to see how it would compare to what we're spending now. We have not been able to do that. I've been pushing legislatively to get that for years. The fact we're actually having debates and discussions like this now suggests we're going to get that to happen. There have been a number of studies of single payer, including in Minnesota. They suggest it's less expensive, period.
But your plan has not been costed out yet.
Mine has not been costed
Thank
out.
you.
We're working on that.
Senator Jensen, curious of your reactions to Senator Marty's characterization of the affordability of single payer and his
Professor
plan.
Jacobs, I'm at the edge of my seat right now. I'm hearing that we're going to get everything and we won't pay anything more than our share, and there's two ways that's going to make it affordable. I don't want to make another comment without hearing those two things that will make this what sounds like Pollyanna. So if we could turn back to Senator Marty, I think that'd be great.
Be glad to.
Senator Marty.
Yes, the first way we have to bring down costs is through price negotiations, through fair pricing. The state of Minnesota did a study in January. They've been putting out numbers every couple of months. They did it on simple knee replacement, ranged from, I think, $40-some hundred to $46,000. 8-to-1 price disparity they found for simple knee replacement. Nationally, 2 years earlier, Yale did a study. $3,400 was the cheapest one. $55,800 was the most expensive. For your math, that's 16-to-1 price disparity. The low-end hospital is not losing money on that. They set that price. That's what they collect for the surgery. They're not losing money on it. They're making money. The one that's charging 16 times as much for the same procedure is making real good money, and we need a logical system. You can't buy one car and you go to one dealer versus another dealer and find 1,600% difference in cost. You might save 5 or 10%. There's no logical price negotiation system in the current system. That's a huge cost savings there. You may not bring it down to $3,400 for every knee replacement surgery, but you're going to be stopping the bizarre situation we're in now. And the second one is administrative costs. And I'm not talking 5 or 10% administrative savings. And the simplest way to illustrate this may be to talk about an analogy of the way we fund our public schools versus the way we fund our hospitals. If we were to fund our schools the way we fund our hospitals, every teacher would have to calculate how much time he or she spent with every student, how many supplies they used on them, send it down to the school's billing office, which would fold in all the administrative overhead, the capital expenses, the janitorial and supplies, everything else, utilities. Then they'd send out bills every month to the parents' school insurance plans. These are expensive plans because education is extremely expensive. So employers would obviously have to step in and provide school insurance coverage for their employees' kids. Not everybody's going to have employer coverage, so we create a marketplace for them. And that's expensive too, so we subsidize that. And a lot of people, even if they have the coverage, they can't afford the co-pays and deductibles. So the school needs a collections agency to do that. Think of all the administrative costs the school puts in place from this, how much time it wastes to the parents. Think of all of the school insurance plans and all the bureaucracies they all have. That's not a small detail. That's a huge detail. Would we do that to our schools? I hope not. It would hugely increase costs and take time away from learning and put it into billing and collection. You eliminate that. That's a huge savings. And both of those two things, those are the two biggest reasons. There are thousands of little things in pharmaceuticals and other things.
Senator Jensen, are you ready to respond?
I am. Thank you. I've seen a lot of people out there with paper and pencil, so if you don't mind obliging me, I'd love it if you just write some of these numbers down. Annually right now in Minnesota, we spend approximately $50 billion on healthcare. Approximately $6 billion are spent by Minnesota on the MA plan. Approximately $6 billion.
That's the medical assistance plan for
Medical
people.
assistance.
Lower.
Approximately $6 billion is spent by the federal to support the medical assistance plan as well. Approximately $10 billion is spent on Medicare, which is funded by the federal program, but we get those dollars and we spend that out. So we have $10 billion, $6 billion for MA Minnesota, $6 billion for MA Fed. Then we have $14 billion paid in premiums. And then we have another $14 billion in basically coming from you folks. Deductibles, co-insurances, out-of-pocket payments, if you will. So we have $14 billion coming from the people, $14 billion in employer premiums. We have $6 billion to fund half of the medical assistance and another $6 billion to fund half, because that's a 50-50 split with the feds. And then you have $10 billion for Medicare. That number comes to $50 billion. Let's say that a company like Blue Cross, which was founded in 1929 and has innovated more and more than you could ever imagine. They were in the paper 2 days ago, and the Blue Cross has come out with, they said, we need to look harder at why do we have these social inequities between how the health and wellness of one race or one group fare versus others. We are seeing the same thing with Health Partners in Cargill right now in terms of putting together an opioid toolkit. So we've seen innovation come from the private sector over and over again. But let's get back to the number. Let's say that the insurance companies are taking too much money, that 85% loss ratio, which means that for every $100 of coming in premiums, they spend out $85 to pay for services. So they're left with 15% in that piece of Obamacare. Let's say we could cut it down by 2/3, so 10% comes out. Well, what are they involved with right now? They're involved with the $14 billion of premiums, and they're involved with the $14 billion of out-of-pocket. That's $28 billion. 10% of that is $2.8 billion. So let's say we could skim off $3 billion. Now, when California looked at their plan to try to go to single payer, what they found was it was going to cost $400 billion. And what they found was they could repurpose the spending they already were doing, and they could come up with $200 billion. And they found that they could get $50 to $100 billion from an employer tax, and then the employers wouldn't have to pay premiums directly. But they still came up almost $100 billion short. And they estimated that when you give something away for free, which has been found before, even so far along ago as Adam Smith, generally there's an inflation, 25 to 30%. If you put that inflation factor that California identified with a Democratic governor and a Democratic legislature and said it was going to be 25%, that means that Minnesota is going to probably have to take 25% of what we now spend, which is $50 billion a year. You're going to have to add on 10 to 12 billion. So now we're at $60 billion. We're at $60 billion, and we can maybe capture $3 billion from taking away the administrative fees that the insurance companies are doing. So we're down to 57. We now spend in our general fund every year, and we now spend $23 billion. And we need to come up with basically $60 billion. The numbers don't work. If they did work, and I appreciate Senator Marty's passion for this, but if those numbers worked, you can bet your bottom dollar Vermont would not have backed away from the table, nor would California. But they have, because it doesn't work. So we need to move on to something else and say, what can work? What's the real moral imperative here? It's the appendicitis, the heart attack, the stroke. It's not who's worried about where they're going to get their sinus infection treated, or whether or not they're going to get 4 paid visits for their hyperlipidemia, their high cholesterol, or not. We need to stop the bumper sticker solutions and start saying, how do we really solve this? And it starts with defining, what do we really need? And we don't need everything. We need something. Because in Canada, they're not paying for prescriptions, they're not paying for vision, they're not paying for dental, they're not paying for long-term care, and they're not paying for home care. And in Switzerland, the whole system is private. And in Germany, which is, quote, socialized medicine, they've broken it up, and they're now getting their insurance from private insurance, from sick funds and everything else. And by the way, in Canada, the government, the single payer, is paying less than 70% of the dollars. 30% of the dollars spent in Canada on their healthcare system, 30% are being spent by people and private insurance. We're spending a little less than 50% in our state, coming from the government. So 70% in Canada, 50% here. We're terrible, and they're single payer. I'm not buying that.
Senator Marty, I can see you eager to jump in. And we could go back and forth on this, and I know you two have. I want to see if I could direct it to the core of what I think is part of one of your 2 reasons, which is about the price that's charged by providers. The point you make about these disparities in provider pricing is very well known. Lots of studies comparing, let's say, Minneapolis to Rochester, New York. You know, these are like studies that are widely known among geeks like me, and our legislators who are also geeks on these issues. And so those things exist. If you steer into the provider pricing and try to cut it, here was the issue that came up in Vermont, and that's been debated nationally among policy experts on both, spectrums, on the liberal side and the conservative side. You would have to make massive cuts in payments to physicians and to hospitals. The estimates are anywhere from 11% to perhaps 50% if we were to bring our costs down to what exists in other countries with national health insurance or single payer. So my question to you is really, I hope, focused, which is, do you think it's feasible to go to the healthcare providers, the hospitals and doctors, and say, you know, we're just paying you too much. We can't afford it. To cover everyone in a single payer plan, we've got to cut your prices by 11%, maybe much higher than that.
If you're working with the assumption that the one place to cut prices is out of doctor salaries, well, I'm sure some could afford that and so on, but the concept that we're going to cut, when I say 16-to-1 price disparities on knee surgery, it's not like it's only the doctor and the hospital making the bills. The whole system is so convoluted. We have a new headline in the Minneapolis paper 2 years ago about a St. Paul startup. I think it's called Athos Company. Good business. They charge like $300 or $500 a person. They'll go over all that person, they work with companies, all their employees' medical bills, and they'll catch errors and they'll help correct them. And they say they'll save more than $300 or $500 that they're charging the company for their employees. That's a wonderful deal for the company, and it's a wonderful deal for the employees. That's $300 to $500 per person per year. They don't deliver one iota of medical care. It's just one more bureaucratic system along the way. Same thing with pharmaceutical prices. Now we have these pharmacy benefit managers. The pharmaceutical companies ripping us off wasn't enough. We have to have another tier in the way that's doing it all convoluted too. The whole process is, if Dr. Jensen's office is going to get compensated a fair amount for everything, he's going to have a whole lot less bureaucratic paperwork. I mean, the number of hours the average physician spends on paperwork is huge. The number that their staff spends is far more than that. You take away some of those costs. When he said, well, we could eliminate if Blue Cross could eliminate 2/3 of their administrative costs. Well, every dollar they have in administrative costs adds another dollar in some hospital or clinic or somebody else, where somebody else has to respond to all the paperwork. All the waste of time doctors spend in terms of prior authorization, sometimes several hours to get prior authorization for one patient. There are huge savings in there.
So, you know, I was actually part of conversations with some of the people working in Vermont. And all these issues that you're talking about, wiping out these disparities and kind of so-called overpaying medical providers, going really hard at the administrative costs, they looked at them very hard with the governor standing over them, you know, not yelling, but really being very stern. He took an oath to his state and said, we're going to do this. And the legislature passed it. They didn't find those savings. So I guess my question to you is, if you've got a liberal state like Vermont who's gone after that, you've got a liberal state like California who's also going after these administrative costs, and they find them, but they're just not near the magnitude to cover the costs. What's going on here? Why is John Marty right and Vermont and California wrong?
Well, first of all, Vermont, we're going to cover, as I said, about 1/3 of their public. How does that save the administrative costs? It's like some people here want a public option for Minnesota Care buy-in. I favor that too as a small, minor thing. It'll affect 3% of the population, make things a little bit better for them, but it doesn't really fix anything. It doesn't save any administrative costs. It's just one more health plan buying into the system. If Vermont has 1/3 of their people covered by this plan, it's not a single payer system. You're not going to have those things. You still have 2/3 of the people are buying their coverage some other way. Every hospital has to have same number of billing clerks. You don't make the savings, so if you don't have a logical system, you don't make those savings. So you have to have a system that makes sense. And my goal is, instead of, this is not a liberal thing or a conservative thing, and actually the polls show that there's pretty good across the board support for this concept, the idea of it. And when you look at how we're spending now, it's not like we have a problem that, well, you know, we're a little bit out of whack. We spend twice what the rest of the world spends per person in healthcare. There are about 8 exceptions who spend more than half what we do, and they're far less than us. But everybody else spends half or less than us, and our medical results are not that great. We're 37th according to World Health Organization in health outcomes. We are way off the charts in pricing, way off the charts. And it doesn't mean, okay, well, I'm going to cut somebody's salary by 30% because we got to take 1/3 of the cost off of it. No, you're going to be eliminating the wasteful system around it. And there will be huge displacement and issues related to that. But it's huge savings that Vermont didn't touch. I haven't looked at what California is talking about. I'm not sure if it's whatever. I'm not trying to argue that. I'm trying to say, here's what we want to do. Not what did they do wrong, but what we want to accomplish.
Senator Jensen?
Thank you, Professor Jacobson, and thank you, Senator Marty. I'm just struck by the fact that we get so polarized. I mean, you're saying that there's broad-based bipartisan support, and yet if you actually go out and look at the data, as soon as you say to someone, are you in favor of single payer, you get something like 70% say yeah. And then as soon as you say, now that would mean that all your health care would come through the government, and you'd basically be in a situation like the VA or Medicare, your Blue Cross would go away. Well, I don't want that. I mean, it changes when we start to define what we're talking about, and that's why I think we really do need to define our terms. The single-payer Canadian healthcare system is not single-payer. It's private insurers, patients, and the government to a tune of 70%. Canada's got 31 million people. Almost 75% of them live within 100 miles of the US border. So they've always got that potential two-tiered system where if they need to, they can always shoot on down to Duluth. And I have patients that have done that are Canadian, and they'll go down to Duluth and get something done because they would have had to wait 10 months if they'd stayed in Canada. I had a patient about a month ago who came in, it was kind of him, he'd brought me a poster of what he saw because he was in Canada touring in the summer and he had a medical problem come up, and so he went in to get health care, and right in their exam rooms they had listed how long the wait would be. If you needed an elective MRI, it was going to be 10 months before you could get your elective MRI. So I think we really need to try to talk about the specifics. If I could get back to the essential health benefits, if we're really going to bring common sense to our healthcare industry, it's going to come from you folks. It's not going to come from the politicians because we don't have the spine to make the tough decisions. We're going to bail because we're always worried about the next election and maybe you won't send us a check. I mean, that's where we go. It's really hard. We need you folks to say, I don't want that. That Lipitor might sound fine to you, Doc, but you know, I've seen the data, and for every 100 people that take the Lipitor, really, in a measurable impact, only 2 out of the 100 will get a benefit. Why does it cost $50,000 to die in Dubuque, Iowa, but $250,000 to die in Manhattan, New York? It's because of the people. It's because of the kind of decisions they're making. It's the kind of advice they're getting from the docs.
So let me just stop you there because I think this is an issue you're both talking about, right? You're both talking about the fact that there is extraordinary excess that we're paying. And this helps to explain why America is spending about 18% of our gross domestic product, almost $1 out of $5. And you're both pointing your finger at the prices that the doctors, and particularly the hospitals, are charging. And let's not forget the pharmaceuticals. So is it possible, Senator Marty, to just focus on that issue, not say we've got to do the whole enchilada? Is that kind of incremental approach? Because I think I'm hearing Senator Jensen accurately. He's saying, you know what, I'm ready to roll up my sleeves. I'm ready to kind of, stand up to some of my colleagues and just say, forget it, we're not going to even talk about this. But he wants to see something that's specific and concrete and not the save the world approach.
I think we have some commonalities. I wrote a book on healthcare. He said he didn't agree with everything in it. He wrote a book on healthcare, doctor-patient relationships. I agreed with virtually everything in it because I think medical decisions should be, I don't want a government-run healthcare system. I want a patient and doctor-run healthcare system, and I think the only way you're going to get that is through a system like this. Incremental approach, I want to make sure we cover everyone. That's the bottom line. I'm not willing to live without that. I don't want to live with a system that says, well, we're going to let decisions be made by insurance companies or government or somebody else. And Scott, when you talk about how, well, if you give it to people whatever they want, they're going to be spending 20, 30% more. I don't know where you come up with that number. I haven't seen that in any academic journals of economic analysis of this. Bottom line is people do want more health care if they're not getting enough health care. Nobody wants more health care. I don't know anybody in this room who's going to say, oh, I love health care and it's all free now. I think I'll go get me another colonoscopy next week. Okay, they're so much fun.
Senator Jensen, you're ready to ask for...
Senator Marty, I applaud your example of the colonoscopy, but let me give you another one. Yeah. My parents both died of it, and so I probably would be one of those people, but my wife is still the one who pushes me, go get your colonoscopy. I do agree with you completely. I think the moral imperative is that we need to provide some basic core package of health care to everyone. We're past discussing it. We need to get it done. I'm with you all the way. But I think you're wrong in terms of human behavior. And it's not bad, but if you watch us when we go through a buffet line and we've paid our ticket, we gorge ourselves and eat things to the tune that we would never do that. I remember I went to this restaurant called Fogo de Chao. And when I got done eating there, I didn't want to see a piece of beef for a year. I almost got nauseated driving by the countryside seeing a cow. No, we do. When we don't have to pay for it, our behavior changes. Folks, we can honestly say that. That isn't bad. That's just who we are. I have patients every day come in and say, Doc, what about a chest x-ray? It won't show us any. Well, you know, my mom used to get them because they came around to the neighborhoods and they took them. I remember Mom getting a chest x-ray in the neighborhoods in Sleepy Eye. But the bottom line is, if someone has a friend who wasn't a smoker and they got lung cancer, oftentimes they'll come say, you know, I've had this cough and it's been sort of nagging. I think maybe a cat's going to be a good idea. And I said, well, your lungs are perfectly clear. You haven't any weight loss. You haven't coughed up any blood. And you got a medicine that causes a cough. Let's stop the medicine first and see if it goes away. We have this. Our appetite is driven by the circumstances that govern our lives. As legislators, we're called to legislate, including our foibles as human, and we have them ourselves. Perhaps the first thing we should do is legislators should have the exact same kind of health care that you do. And if we did, then maybe we'd be more intellectually honest. Certainly at the federal level, they have quite a health care plan. I tell you, I can't believe it. But I don't think you can trust doctors like you used to be able to. We're too jaded. We've drunk the Kool-Aid. You have to trust your own gut. Lipitor is not for everybody. Did you see the article a couple months ago? They came out and says, you know what? Lipitor in people over the age of 65 that don't have the diagnosis of diabetes or heart disease is not a good thing. I got an article last week in the journal that says, does Lipitor help prevent the onset of dementia? And I thought, well, this will be a good one. So I read the article. And the last paragraph said, well, no, it doesn't. And never mind the fact that Lipitor can actually cause a delirium syndrome consisting of memory loss and confusion. Because if it does do that, just stop it and it'll probably go away. This is the kind of stuff we're doing. Do statin drugs cause diabetes? Yes, we know it does. Do you know what our literature tells us? If I put you, ma'am, on Lipitor and I cause you to have diabetes, at that point in time, you might say, gee whiz, let's stop the Lipitor and see if the diabetes goes away. No. Medical literature says I should up the Lipitor because you now have diabetes and the standards for your cholesterol measurements are now we have to lower it lower. Now, how dumb is that? And we do this every day. So you're part of the solution, we're part of the problem, and you can't have it all. It's that simple.
So, Senator Jensen, let me follow up with one of the points that you've been gently making.
Gently?
Yeah, I think you've been gently questioning the role and scope of government. You've presented it, in fact, the most graceful way I've heard from a Republican in some time, and I appreciate that. But let me ask you this, because we're now getting data. We're almost 2 years into the Trump administration, and we're getting some data here in Minnesota. The uninsurance rate is up almost 50%. And one of the things we're hearing from those who are no longer insured, which is over 350,000 Minnesotans who've lost their insurance, is that they can't afford it, that their coverage has gone away. Does that lead you to think we got to be careful here, and government has a fairly substantial role to play here, and that we need to be looking for ways, maybe not to go as far as Senator Marty, but looking for ways to expand the government involvement with regard to affordability and coverage?
Thank you, Professor Jacobs. That's a great question. Senator Marty and I had a chance to discuss this issue on a different program probably 6 months ago. And after that discussion, many of the points he made really pushed me to get more data and learn more. So I called Stefan Gildemeister, who works for the Department of Health. And I said, Stefan, I need to understand who these 350, 400,000 people are in Minnesota that don't have health care. What do they look like? What's the face of these people? And so he got me probably 5 or 6 pages of the data, and then I called him and said, let's go over it. More than half the people that don't have coverage in Minnesota right now are eligible. We have to help them get signed up. Of the half, say 175,000 that aren't, there's at least a third of those probably could become eligible if we tapped into all the sources we have. So we're talking about literally less than 2%. In Switzerland, where they say they have universal coverage, they call it 99.5. So they're still short 0.5%. And we're less than 2% in terms of if we could get everybody plugged in that's eligible. So we're close. We've got a public-private partnership that works. We have insurance companies that have done good work. Undoubtedly, they've been abusive at times. Profit is a powerful motive. But you could say the same things about physicians and about hospitals. What we need to do is go the rest of the way. And I think that Senator Marty's right. The way we get the rest of the way is we say the moral imperative is that everybody's got to be covered. So why don't we do what we do now with someone who could qualify for medical assistance, comes to the hospital emergency room and doesn't have a card, doesn't have coverage. It's called presumptive eligibility. We have that in place right now. The hospital can go ahead and initiate an application for coverage. And so that person with chest pain or maybe half of their arm cut off can get cared for. Okay, why don't we do that? If in Minnesota, you go to the emergency room and you don't have anything, let's put a system in place so that we do satisfy that moral imperative. And we can do it. And that'd be a whole lot cheaper than turning the whole thing over to the government. Government does some things well and some things not so well. We have to be honest. Government does a good job with Social Security. They get a Social Security number, they check your age, they see how many years you paid in, and they write a check. They do that well. Do they do so well with child care, elder abuse, MNsure exchange, MNLARS? To take a $3.25 trillion industry, which government now is involved with about $1 trillion of it, and to say, it's all yours, the whole enchilada. We know that you can do it. We've got faith in you. I don't think it's going to work. And I think if we did do that, patients would lose choice. And that's critical. Patients should not be told that they have to have a flu shot. Patients should be allowed to choose.
So, Senator Jensen, I think we just made some progress here. I'm hearing you, despite your earlier comments with regard to my comment about moral imperative, I'm hearing you embrace it now. And I think I'm accurately characterizing what you said, that you embrace the moral imperative that Senator Marty has articulated, that everyone should be covered.
Basic core package.
Basic core package. Senator Marty has a larger package, and it sounds like there's a good debate there, which we don't have to go into right now. But Senator Marty, let me come back the other way. One of the issues and questions about single payer and about your proposal is about whether it's politically feasible. Would it ever pass, or is this the kind of pie in the sky idea? Lots of reasons why I could see you being more optimistic today, including all the Democrats running in Minnesota and around the country are now saying they're all for single payer. Though I think we'd both agree with Senator Jensen, they may not mean the same thing you do. My question, though, is given these hurdles for passing single payer, doesn't it make sense to kind of see Senator Jensen as an ally and see where you can work together to build out the public part, to strengthen the private elements of our healthcare system and grab that win?
First of all, I think what we're talking about is a public-private partnership. Our payments would be made by the Minnesota Health Plan. If you want to call it government, I call it, it's sort of a quasi system, would be separate from government, but call it what you want. The payments would come from there. They would be legally required to make sure there are no waiting lines by making sure we have an adequate number of providers, 10 basic principles for healthcare system that would be legally binding on the Minnesota Health Plan Board. But yes, it's a public-private partnership, and so I don't know where the government and non-government is, and I don't spend my time fighting over it because this is not a government takeover. You'd have more choice in this, choice of provider, medical decision, and so on. But yes, in terms of working with him, of course. If we got a single-payer kind of thing that guaranteed coverage, basic stuff, basic passage, whatever you want, yeah, I kind of think everything like dental and other things are a pretty important part of your health care too, but I'll take what we can get. I mean, it's not like I've done 30 years in the legislature saying, well, if I can't have it my way, forget it. I'm always working for it. I support the Minnesota Care buy-in as a little tiny step forward. Not a fix, but it makes life better for some people. So no, I'm always willing to work together on that. And I do think that part of when you talk about the buffet line and people just, you eat too much at a buffet line, well, there's a huge difference there. For one thing, we like food. We don't like medical care for the most part. And I mean that. We don't like it. And the other thing is, in the buffet line, if you think about it, if you say, okay, there's going to be this food available, how much of it do you want? And you decide ahead of time, you probably make a more rational decision. With healthcare, you're not kind of, I'm in the doctor's office, oh, what can I get? What can I get? Please do something more to me. People don't do that. And so they think ahead about it. And when you say you don't trust doctors that way, I realize doctors have conflicts of interest here. All of that is stuff that we have to address in the healthcare system, and our proposal requires the health plan board to root out those conflicts of interest so a doctor can't get more money by prescribing or ordering procedure. They get their payment for treating the patient, for their time with the patient, for their knowledge with the patient. And if you look, Gunderson Healthcare in La Crosse, Wisconsin, or wherever, they tried about 10, 15, 20 years ago now. They decided they wanted patients to have more choice. So they were having doctors actually spend time with their patients trying to get them fill out what we'd call advance directives or living wills and so on. They weren't doing it to save money. They were doing it so people had more choice in their health care. And what they found out was it saved buckets of money too, because when patients talk with their medical providers about what kind of care they need, people don't want things that don't help them. I don't want Lipitor if it doesn't do me any good. And our plan actually addresses some of those conflicts ahead of time. The only prescription drugs we would ban the health plan from covering are those marketed direct to consumers in Minnesota, because we can't stop that. That's $200 million a year. And they do that because it gets people to want more health, more pharmaceuticals that they don't need and so on. We got to address all those conflicts, but I'd love to work with you and so on. That's why, I mean, Scott is a new member of the Senate and one of the folks who wants to be serious about this. I'm glad to work with you. I think we can accomplish good things.
Do you hear this all over the country? I don't. I want to thank both of you gentlemen for that. We've got a lot of questions here from all of you, and I've been feeding them into the questions that I've been asking, and I want to steer more directly into some of them. Senator Jensen, a question from the audience. Physicians spend 2 hours of administrative time for every hour of patient timing. There was apparently a recent article in the Annals of Internal Medicine on this study. Thank you for the citation. Much of this is related to documentation for billing. How would you deal with this waste in the current system?
Thank you for the question. The question gets to the electronic health record. The way I dealt with it is when I built a clinic 18 years ago, I said, I'll be damned if we're going to do an electronic health record, so we don't. We're 100% unhackable. People can't get at our charts by going into their internet. I understand that some things are terribly important for multiple people to have access to. An MRI of your brain. We definitely need that available on the floor of the hospital. I need it as your family doc. The internist may need it. We need that kind of thing. But quite frankly, a lot of what you need in healthcare isn't really that important a month from now. It's just important now. Did we finally get your blood pressure under control? Did we take care of your strep throat? Is your A1C and your diabetes managed now?
But
let me just finish that if I could. I'm sorry. But the bottom line is we do spend a lot of time documenting because, one, if the insurance companies audit us and we don't have the documentation, we don't get paid for it. Two, it's the thing that keeps us safe in a court of law. But the bottom line is we're wasting a lot of time because we should be focusing on your agenda. And a lot of times we don't, because we know what we have to do in order to wrap up that visit to get paid, protect ourselves against the auditors, and protect ourselves against potential tort.
And I see Senator Marty nodding. It looks like, Senator Jensen, you've just become a witness for the very case that Senator Marty has been making here today, that too much time of the doctors and other providers is spent on unnecessary administrative costs and process. Senator Marty, I've got a lot of questions here, so I want to be a little stricter, and I'm going to try to get us through a lightning round here. Okay. A question for you. If we go to single payer, what do you envision happening to all those currently employed in private insurance?
That's a very good question because it's a very important one, and I don't think we should pretend there aren't difficulties when you say, is this feasible? Yeah, that's one of the huge challenges. There's one estimation of the number of jobs that would be lost, and they're not just insurance companies. They're in hospitals and clinics and everywhere else too, because every bill that's sent out from one place has to be collected at the other end and all of that. And bottom line is there are about 4 times as many people who switch jobs in any given month as would be displaced by this. It's about 38,000, I think, versus 155,000 job transitions in a month. So it'd be a huge issue. Our bill would be bound, the health plan would be legally required to provide dislocated worker benefits. It would be required to provide retraining. And it's a huge shift in the economy. That's why it's a difficult issue to pass. I don't want to gloss over that. I don't want to pretend this is, oh, we're just going to pass this next year. It's going to be real simple. Because it's not that at all. It's a huge shift. But the bottom line is, without doing that, we don't fix the system. And if we can, I would much rather pay somebody to sit in an insurance company office or a billing office and do nothing than pay them to do what they're doing now because of all the convoluted thing. And when you get to the doctors wasting time filling all these things out, they should be keeping medical track of what their patients need, not medical track for billing purposes, because that's where you get the huge convoluted mess.
Senator Jensen, question for you. If single payer is a bad idea, then should we abolish Medicare?
The question, I don't think I've ever said single payer is a bad idea. I think that in putting it in place, I think the unintended consequences of perverse downstream incentives it will have created will be problematic. Medicare is a program that's worked extremely well, but let's face it, it's for people that are 65 and older, and they've earned it. They've worked, they pay taxes and that, and it works very well. And I think that if you actually look at who uses our healthcare system most appropriately, I've participated in studies on that. It's the senior population. In terms of who uses the emergency room most casually when they shouldn't, who uses it most responsibly when they should, studies have demonstrated over and over again, the senior population is very, very appropriate.
So if you're in favor of Medicare, and I assume then you would be in favor of some of the Democratic proposals to expand Medicare to earlier populations, let's say down to 50 or 55, and you would only get access if you paid into it. Would that be okay?
I think the moral imperative is to provide a core package of care for everybody, and I think we have to define what that is. I don't think that expanding Medicare for all is the way to get there. I think we have better options. I think we could deal with the pharmaceuticals. We could preserve choice. We could rein in conflict of interest. We could bring back some of the patient protections regarding anti-fee splitting and anti-self-referral. We could stop the waiver of monopolization. The FTC has waived that with the Affordable Care Act. We've had more consolidation in the last 5 years than we've ever had, and it's not driving the price down, it's driving the price up. Medicare for all, could it work? Throw enough money at it? Probably.
So I wasn't referring to Medicare for all. I was referring to what's known as Medicare for more.
Fair enough.
Which extends the very principle you were talking about of let's bring in other populations that pay in and therefore earn a right to it. Senator Marty, I've got a question here for you. You've been talking about your plan, which is for Minnesota, and the question is, why should we be looking for a Minnesota approach? Why not just favor Medicare for all and have a national approach?
I think the urgency of getting health care for everyone is such that we should be fighting at the federal level and at the state level. It's too important not to. And the Affordable Care Act, as I said, I think it did some good things, some things that weren't particularly helpful. But the bottom line, pre-Affordable Care Act and post-Affordable Care Act didn't solve the problems. Scott mentioned how one of the good things it did was allowed students, parents, to continue covering their kids until they turned age 26. Well, headline in one of the papers 3-4 months ago about a 26-year-old Bloomington kid, a Richfield kid who lost his parents' coverage at age 26. A month later, he was dead because he couldn't afford the insulin. And that's a tragedy. And the thing is, that happens so often, it's not in the newspapers. The only reason it made the newspapers this time, kid died a year earlier, but his mom got involved. She was so fired up about changing things that made a headline. But it happens all the time, and I want it to happen. I don't care if it happens at the federal level or the state level, and I'm not using Canadian analogies because I'm not trying to design a system like Canada or anything else, and ours has a lot of things that theirs wouldn't have, and avoids the problems of waiting lines and so on. But I will say, in Canada, they did pass their single payer in Saskatchewan in 1962. Within a decade, it happened nationally. So that's why I think doing it in one state, you know, if it's cheaper and makes sense and covers people better, it expands quickly. But I'm happy either level.
Senator Jensen, here's a question for you, I think from one of our conservative friends who are here, who are surprised that you haven't talked about a voucher system. What about the idea of creating a voucher where all insurance companies must take this voucher for defined benefits? It gives more freedom to the individual and puts power in their hands.
Thank you for the question. Actually, we have discussed this, particularly in regards to the medical assistance population. Indiana has something like that, where you basically get a funded HSA, and it's funded by the state, and that way people can take that. It provides a lot of incentives for people to be good stewards of the healthcare dollars, and if at the end of the year they haven't spent them all, they get to roll them over into the next year. There's Dr. Bob Geist has worked on a thing called Family Medical Account, where people would do the same thing. It's sort of a voucher thing. So this has been discussed. I don't think it's gotten a lot of traction just because it smacks of expanding the government role. And I think that's why in our Republican legislature it hasn't gotten so much traction.
Senator Marty, how do you contain costs in a program that promises 100% of everything? In Vermont, they excluded dental care and other services once they realized the cost.
Let's take dental care, take long-term care, because you don't count them in the system. Oh, then it's free. Government doesn't have to pay anything, so nobody's paying anything for dental care. No. People are still getting dental care, maybe not enough, and they're getting their teeth pulled instead. But the bottom line is, if people need medical care, it's being paid for. The question is, in Minnesota, long-term care, some people said, John, your plan shouldn't cover long-term care. That's expensive. In Minnesota, long-term care, according to Stefan Gildenmeister at Department of Health, 3/4 of our long-term care costs are already paid by government. So we have every senior or near senior saying, well, maybe I would buy some sort of long-term care insurance and fighting over that. And we have everybody trying to hide their assets from the government trying to collect all that. All those fights, all those worries, all that other stuff, over 1/4 of the cost of long-term care. Why don't we just cover the whole thing? So, I mean, when you talk about these extra things, yes, if it's care that people need, a healthcare system ought to provide for that. That's all I want, is a common sense healthcare system. And if somebody, the whole idea of dental care being separate, you know, dental care probably has more to do with infections that can affect our heart and other things than finger and toe. We don't have separate finger and toe insurance. I mean, I shouldn't say that because someday we'll get that if we don't change.
We're just about out of time. I want to do 3 things before you all get up and leave. First, I want to just give you a heads up about coming programs. Tomorrow we have a terrific program here about seniors as the key swing vote. It's at 11:30. We got more information up top if you'd like it. I've been very concerned for a number of years about our budget deficits, and I remain so. We're holding a simulation with the Concord Coalition. This is not like this. This is you make the decisions. It's a simulation. You get the data. You design what you think is a responsible approach. That is Thursday, this Thursday at 3:30. We have a terrific program coming up towards the end of the month on October 25th with Jake Sullivan, who worked closely with Hillary Clinton in the State Department and elsewhere, who was a key person in designing the Iran agreement, which President Trump has now walked away from. Here's what's interesting. Jake Sullivan is coming to talk about why the international system remains vibrant. I was surprised by that. We've got Bill Galston coming to talk about dysfunction and civility in our politics, which is part of this series. And that's October 31st at noon. And then we have a program with the head of the legal work at the ACLU, David Cole. He's going to be talking about national security in our Constitution. He's been working on these issues for 3 decades. The same set of issues, whether it was President Clinton, President Obama, President Bush, President Trump. He's not a partisan guy. It's just trying to defend the Bill of Rights. I think he's absolutely astounding, an important figure in a country. November 14th. Quick thank yous. Thank you very much, Scott Kiefer, the best possible partner. We go back and forth. Scott said he wasn't that comfortable with the idea of single payer. It's very true, and we did the program. and we're going to do another one, I hope, in the new year. And I really value that partnership. These events do not happen by themselves. Mike Carey up here and Lee Chittenden are magicians. I've lost track of how many programs we're doing this fall, but let's say it's a dozen or it's 15 or whatever. They are just incredible. And our great panel. Senator Jensen, Senator Marty. I'm not going to speak for you all, but I'll just tell you this is what I miss. I'm tired of being shouted at. I want sensible conversations with people who disagree, but can disagree in a way in which we learn and we can see a path forward. So thank you for that, and thank you for joining us today, and thank all of you.